Good afternoon, and thank you for joining us today. I'm Jennifer Stripay, a member of the School of Medicine and Dentistry's class of 2016. I'm currently a scientist at St. Jude Children's Research Hospital in Memphis, Tennessee, working with Dr. Martine Roussel. My research is focused on understanding mechanisms of disease in pediatric brain tumors and developing new therapeutic approaches for this patient population. I'm also the president of the School of Medicine and Dentistry Alumni Council, which is an advisory council to the dean and is supportive of the faculty, administration, students, and alumni. Today's lecture is part of a new series called Experience Rochester that exemplifies the university's commitment to lifelong learning. The series features topics and speakers unique to the university. We have a wide range of registrants joining us for this session, from parents, current students, to alums from as far back as the class of 1950, and a few joining us from the class of 2024. Before today's webinar begins, I'd like to share a few Zoom webinar tips. If you'd like to ask a question, please submit it through the Q&A function that's located at the bottom of the screen. Professors Foxe and Silverstein will answer questions at the end of the presentation. If you'd like to view this session with closed captions, please click CC on the bottom toolbar and select Turn on Subtitles. If you're having any trouble viewing the webinar, you can call in and listen using the phone number that was included in your confirmation email. And now I'd like to introduce today's speakers. Dr. John Foxe is the Kilian and Caroline F. Schmitt Chair of Neuroscience and the Director of the Ernest J. Del Monte Institute for Neuroscience. His research investigates such developmental disorders as autism and schizophrenia. The core mission of his work is to understand the underlying biological mechanisms of these diseases, with the goal of developing more effective treatments and interventions. Steven Silverstein is the George L. Engel Professor of Psychiatry and Associate Chair of Research for the department. His research studies retinal, perceptual, and cognitive changes in people with schizophrenia and rehabilitation of those impairments, as well as mental health issues related to vision loss. He's the former chair of the American Psychological Association's Task Force on Serious Mental Illness and a former executive board member and past president of the Society for Research in Psychopathology. Thank you again for joining us, and I'll now turn it over to Professor Foxe.
Sorry, let me begin again by welcoming all our alumni and friends of the University of Rochester. I'm John Foxe. I direct the Del Monte Institute for Neuroscience here at the University of Rochester. And I want to thank you all for joining us, and we'll begin with just a few slides to bring you up to date on what is really fast emerging information regarding the impact of this virus on brain function. And so let me begin here. I'm hoping that you can all see my slides. I want to advance. I just wanted to, you know, as a health professional sitting in a medical center where we're very concerned about the health of our community, just want to remind people that we are still in the middle of, if indeed you needed any reminding, of a very serious situation. And these are the data from yesterday from the CDC with over 2 million confirmed cases. And as you can see, a really terrible mortality rate at this point. And one of the things I think that it's worth noting, although I'm sitting in New York State where our numbers have gone down considerably and are looking quite promising, if you look across the entire nation, you can see that we peaked here in early April. And it's been a very slow process to get those numbers down. And yesterday we had nearly 28,000 new confirmed cases. And of course, there's more as we test more. So we're still right in the middle of this. Now, quick note as well, because some of you may indeed be frustrated with all the various names that are being thrown around. And we scientists have a tendency to try to complicate things with jargon and wording. So here's two things to know. When we talk about COVID-19, that's actually the name for the disease. And as if you have the disease and you're suffering from it, you've got COVID-19. And it's caused by what is now known as the severe acute respiratory syndrome coronavirus 2, so SARS-CoV-2. So when you hear those two names thrown around, SARS-CoV-2 refers to the virus and COVID-19 to the disease. And one thing I think as a point of clarification, would be that one really needs to think about COVID-19 in a non-binary way. That is, it's not a black and white situation. There's a very strong tendency to think of just two possible outcomes: mortality, so you pass away, or survival. But as with most things in our lives, there is a very large gray zone in between. And while survival, of course, is the ultimate goal and is terrific, for many, it's just the beginning of a long road and a life that may really never quite look the same again. And that is the kind of thing that keeps folks like myself and Professor Silverstein, who you'll hear from shortly, up at night, which is that we expect that many of these people who have been severely ill or even moderately ill will continue to have, and the disease will continue to have an impact on them in the months and years ahead. And of course, another thing is that we hear a lot about asymptomatic disease and youngsters who get it but don't really show any symptomatology. But we still are yet to understand if what looks like overt asymptomatology has no deleterious outcomes. It may be the case that there are other latent factors that will emerge as we go forward. And that's an important point as well. So, now, here's what's worrying us. About half of hospitalized coronavirus patients experience neurological symptoms, including dizziness, difficulty concentrating, the famous loss of smell and taste, seizures, you'll have been hearing about that, strokes, and weakness. And this is very recently reviewed in the Annals of Neurology from a number of studies that are coming from all the various countries in the world that started ahead of us, including our own. And I just took one of them to give you an example here. So here's a study out of the University of Strasbourg in France. And what they did was they followed all the patients that arrived into their hospital, were hospitalized or admitted to hospital with the COVID-19 symptomatology between March 3rd and April 4th, so over the course of 1 month. They had about 65 or 66 patients admitted. Some of them were critically ill and essentially didn't make it into the study. But of the 58 patients that were admitted to the hospital in this period, these folks had a median age of about 63, so they ranged from young adults to elderly folks. And what they saw was that 49 out of 58 of them, that's 84%, 4 out of every 5, showed what we would classify as clinically meaningful neurological signs. And of those 58 individuals, they had enough cause for concern to send 11 of them for an MRI scan. And in those 11 individuals, these are people who are showing neurological symptoms, all 11 of them showed perfusion anomalies. That means that there was blood flow differences mostly in the frontal part of the brain in all 11 of them. And in 3 of these individuals, they actually found MRI evidence for acute stroke, which goes to some of the blood clotting issues that you'll have been hearing about. So 3 of the individuals actually had clear MRI evidence for, mini strokes in their brains. One of the key points here, and this is the point I was mentioning before, which is of 45 of these patients who recovered and were discharged from the hospital. So in essence, they no longer had the COVID-19 disease. They were virus-free. They'd raised those antibodies, fought off the disease. 15, so fully 1/3 of them, showed dysexecutive syndrome. That means their executive function, their thought processes weren't great. They had inattention, disorientation, and poorly organized movements in response to command. So 1/3 of those recovered individuals were still showing really significant clinical neurological symptomatology. And again, that's one of the things that we are concerned about. This paper literally came out in the last couple of days in the New England Journal of Medicine. Now, a question that arises then is, does the coronavirus actually get into the brain? And you'll all have heard, even those of you who don't have a scientific background, will have heard of the famous blood-brain barrier. And that is our brains are protected very well by this barrier, by this cellular barrier that stops large molecules and other unwanted materials from gaining access to the neurons in the brain. And only very, very small, so this is just a depiction of it here in my slide, but only very, very small molecules can actually cross this blood-brain barrier into the brain from the bloodstream. For example, this morning you probably all got up and had a cup of coffee or tea to get yourself on the road. Caffeine is one of those nice small molecules that's able to travel across the blood-brain barrier. But this barrier really protects our brain from pathogens. The question here for us would be, can the COVID-19 virus actually get across this barrier? How does it gain entry? And again, one of our key suspects here is actually the olfactory system, your smell system. And so let me do a very quick primer on that. Many of you may know this. So here's a slice through a cartoon of a human head. And one of the amazing things about the smell system is this is one of those systems where the brain actually essentially pokes out into the external world to sample the molecules that are coming in through your nasal passage. So as you breathe in here into the nasal cavity, these neurons are actually projecting down through the skull to sample the air, to tell you what's out there and what you need to avoid or go towards. If it's the nice smell of baked bread or that cup of coffee I mentioned. And so the neurons that are poking out into the world send that information up into the olfactory bulb and along the olfactory tract and on into the rest of the brain for analysis. And so how do they poke out? Well, what they do is they actually descend through what's known as the cribriform plate. The cribriform plate's a really amazing structure, because what it is it's a tiny little set of perforations here that the neurons grow down through. It looks like a little bit like a sieve. So here's actually a sawn off. This is the skull. We're looking down from the top of the skull, and it's sawn off. This would be where the nose is. This is the back of the head here. There's the cavity for the spinal cord to exit down into the body. And up here is where this olfactory bulb and the olfactory tract sit. And you can see it's highlighted here with these little orange dots, but there's this nice sieve-like structure here so the neurons can descend. And they're supported by a whole bunch of other types of cell types there. And you will all at this point be aware of one of the symptoms that has been associated with COVID-19, and that is anosmia, which is basically the failure to be able to smell things. And here's a case, so that's been puzzling scientists, neuroscientists, since we first learned about it just a matter of weeks ago, really. But here's a case of a 25-year-old female radiographer. So this is somebody, young woman, who was treating COVID-19 patients. She's doing imaging on the patients, and she developed this famous anosmia. She lost her sense of smell, and indeed turned out to be infected with the SARS-CoV-2 virus. And when she was put in an MRI scanner, what was found was that there were actually signals indicating viral infection. Here you can see this sort of intensity, the whiteness of this here, a hyperintensity, in what's called the right gyrus rectus, which is not of any great importance, but this is an area that processes smells. And actually, if we keep going forward here, what you can see is here are actual images of, that's the olfactory tract and the olfactory bulbs, and you can see the hyperintensities there. And so the implication was that the virus was infecting actually not the neurons in the smell neurons, but actually the support cells around there that have the receptor that the virus prefers. It's called the ARC2 receptor, and the virus was able to travel up through the cribriform plate into the brain. So that's one of the big suspicions. Now I want to just say really quickly, this is a single case study I'm showing you here. And that's unfortunately the state of where we're at the moment, because large scale studies like this are very, very difficult to do. It's a fast moving situation. Now a question then becomes, well, what happens if the virus actually gets into the brain tissue? Will it be taken up by neurons? Will it replicate? Can the virus live in the brain? Does it do its damage in there? And so I wanted to introduce you to one of the pretty extraordinary techniques that are available to neuroscientists today. This is a technique that was developed in a number of labs, but in particular at Johns Hopkins University. And these are what we call brains in a dish, spheroids, brain spheroids. And these are these tiny little clumps of neurons. So what happens here is scientists will take a little skin biopsy, and in that skin biopsy, or it doesn't have to be from skin, but other parts of the body, sometimes tooth pulp will work very well. There are stem cells. And these scientists, what they've done is taken these stem cells. These are cells that don't yet know what it is they want to be when they grow up. And they program them and turn them into neurons in these clumps. And what happens is these clumps of neurons will actually self-organize into little organelles. So they're little mini brains. They don't have any functional value, but the neurons work, and all the sort of characteristics of neurons are in there. In fact, there are multiple neuronal cell types. So it starts to mimic aspects of brain function. And this little 3D one here shows you one of these clumps of neurons. And these actually, you can see them with the naked eye. You can see here the measurements, 350 micrometers in diameter. They're about the size of the eye of a housefly. And so just about visible to the human eye if you've got good vision. And so I'm about to show you data actually that were sent to me just yesterday by Thomas Hartung and his colleagues at the Johns Hopkins University. And he was one of the original inventors of this technique. So these data were literally just submitted for publication. That's how fresh we are in this process right now. We're learning literally by the hour and by the day. What they did was they developed their brain spheroids, put the virus on and asked, can the virus get into the neurons? Can it replicate? And what they showed, in fact, here's the spheroid that doesn't have the SARS-CoV virus on it. And here's the spheroid some number of hours later. And you can see the uptake of the virus here. It's stained in red. And the virus is getting into the cells, into the neurons, and is replicating at a fast rate. So you get a 10-fold increase in the amount of virus in the cells. And indeed, afterwards, you get a extrusion of the virus into other neurons. So it's traveling through this. So this is very fresh information. Now, we'll just say one thing here is these spheroids, right, they're in a dish, so there's no blood-brain barrier protecting them. So we don't know that this is what happens, but what we do know from the spheroids is that if the virus gets into the brain, then it has a good chance of replicating because it does so in neurons in a dish. Okay, I'll try to wrap up now. So what about vertical transmission? What does vertical transmission? Vertical transmission is what if a pregnant mother gets infected with the virus? Will the virus travel into the fetus? Will it have an impact there? And the first thing to say is we don't know yet. And there's a really simple reason for that. And that is that if you look at the time frame here, here's our numbers again. By the time we were up above 20,000 cases and we would have had this large numbers of individuals being infected, you can see it's really April to May of this year is where we started to head into this 20 to 30,000 confirmed cases a day range. Well, if you think about it, if a mother was pregnant here when she contracted, we're only just beginning now to see the first babies born to mothers who were infected with COVID-19. And those babies would have been in the third trimester because they're now coming to full term. So second trimester infections from the initial surge will be coming to term between July and September of this year. So we haven't seen that wave of youngsters from this stage of pregnancy. And of course, we won't see the first offspring that are infected or potentially infected during the first trimester until October through December, January of the new year. So we have a lot to learn here. We haven't actually seen these babies yet. But we have some hints. Now, there is another couple of things that really are important to realize, which is that the babies, is particularly in these early stages, the first and second trimester, they don't have the benefit of a tightly coupled blood-brain barrier. If something goes into the mother and it can pass through the placenta, it will go into the brains of those youngsters. And that's why we're very careful, for example, when we make recommendations about alcohol and caffeine and other kinds of intakes in pregnant mothers, because we know that those compounds can get into the baby and change aspects of brain development. So is that going to be the case with COVID-19? And the answer right now is we don't really fully know, and that's still to be learned. So I'm just repeating that here. We've yet to see whether there are implications for babies born to mothers who've contracted COVID-19 in the first and second trimesters. The children simply haven't been born yet. But we do have very recent evidence that it can be transmitted vertically. And that is the worry. So there's a study that just came out again. These are case studies. We're literally learning one patient at a time. But a group at the Paris-Saclay University Hospital in Paris presented a case study showing infection in a newborn with evidence for neurological findings. So these are MRI scans from that new baby with these little white matter hyperintensities here, excuse me, showing that this child was born with neurological signals. Now, it's, again, I caution, it's a single baby. It's possible that this mother who had COVID-19 had other issues, or that the child had other issues, and that these are not related to the COVID-19. But what they were able to show through blood work and through work in cerebrospinal fluid is that the child had indeed been infected with the COVID-19 virus. That doesn't mean that every child in utero will be or has been, but it's a worry. I wanted to finish with one quick slide because this is near and dear to my own heart. Here at the Monte Institute for Neuroscience at the University of Rochester, one of the major foci of our work is on individuals with intellectual and developmental disabilities and on autism, as was mentioned by Jennifer in the introduction. One very distressing number that's coming forward now, as you can see here, is that people with intellectual and developmental disabilities that contract this virus are more than twice to 3 times as likely to die. So these are mortality rates here in New York. You can see that 16% of the folks with IDDs that show up in the hospital have a poor outcome, as opposed to 6% of the what we call the neurotypical population. And in Pennsylvania, you can see somewhat similar numbers, slightly better. And I just want to point out that this is a matter of great concern to us, and we're trying to get to the bottom of this. Obviously, individuals with intellectual developmental disabilities often come with other comorbidities, and as you all well know, comorbidities are the name of the game here: obesity, aging, intellectual disabilities, the other comorbidities that make you more vulnerable to the ravages of this virus. So that's the formal component of my little didactic piece here, and I'll be available to answer questions afterwards. I'm going to hand over the mic to my good friend and great colleague, Steve Silverstein, who's a world-leading expert in psychiatry, and he'll talk to us a little bit more about the psychological impacts of the disease. Thank you very much.
So, well, hello, everybody. I'm running backwards through my presentation now. Apparently, it was at the end from when we went through it before. But anyway, thank you for joining our webinar today. And my goal with the slides that I have here is really to talk about mental health issues, which is becoming increasingly a problem here, as we see. I just want to start out with some headlines that you may have seen or seen things like this. So, of course, coronavirus is a potentially fatal disease, but more and more now people are focusing on mental health issues. As you can see here and here, this was a report from a few weeks ago that 1/3 of adults showed signs of anxiety or depression during the pandemic. Again, some of this was thought to be related to loss of income, loss of jobs. And in general, now that the curve for new cases and mortality is flattening, it seems that there's another curve that's happening, which was related to mental health. So this is becoming quite a big concern. A very recent study just published last month in the Journal of the American Medical Association showed that compared to just 2 years ago, in terms of these routine surveys that are done, the rates of depression and anxiety, distress are much increased compared to the same time period 2 years ago. And that's pretty much in all groups of people, men, women, different races, different incomes. And the thinking is that much of this is due to the recent pandemic. Now, of course, one of the questions is how much is directly due to the effects of the virus and how much is a secondary effect of being socially isolated, et cetera. So that's something we'll talk about in a minute. But I just wanted to make clear to everybody that this does seem to be a serious problem now in terms of mental health. And one of the other issues that's come up is not just the problems with mental health in the general population, but also in health workers. Of course, that's always a stressful and potentially dangerous occupation, but especially when you're dealing with fatal diseases. So very recent studies, such as this one that came out last month, are suggesting that rates of depression and anxiety are significantly elevated in healthcare workers. Here's another one just from very recently. And in particular, it seems to be that over 20% of professionals are reporting symptoms of depression and anxiety And many people report other symptoms, such as a 40% rate of insomnia. And this does seem to be a larger problem among female healthcare workers, especially nursing staff, and those, nurses typically are the people with the most and closest contact with patients. But many people also have milder symptoms. And so recommendations now are for regular screening for mental health concerns symptoms among healthcare workers. Now, what are some of the potential mental health consequences? Of course, we've been hearing about anxiety and depression. But as John was saying, much of what actually will be the final answer is really unknown. As John mentioned, in the short term, we know that many people hospitalized with COVID-19 show signs of delirium. They show poor concentration, confusion, rapid mood changes, etc. So we know that there are effects on the brain fairly early on in this. And as I said, some of this data is from older coronaviruses, SARS and MERS viruses, but it does seem from COVID-19 data that it's the same. In the long term, there's of course less known, but based on what happened in the SARS epidemic about 17 years ago, we expect to see, and already are seeing, but expect to see more of depression and anxiety, but also other serious symptoms of mental distress, such as self-harm and suicide, both immediately and in the long term. So just want to mention a few things that happened during and after the SARS epidemic, which was a coronavirus. There was about a 30% increase in suicide among people 65 and older during and after that pandemic. That's quite serious. And about 50% of people who had SARS and recovered reported remaining anxious months after the infection had resolved. 6 months after the infection, so again, many people had gone back to whatever, their regular life, but there was still about 15% with significant levels of depression, 15% with an anxiety disorder, about 20% with chronic fatigue, and about 30% with symptoms of post-traumatic stress disorder, or PTSD. So again, you can see why people now are saying they're expecting a significant increase in mental health issues. But there are other issues as well that go beyond just symptoms that individual people might have. For example, very early on in the pandemic, when social isolation was starting, there were reports of increased domestic violence. And there were also reports of increased child abuse. Now, one of the very concerning situations with child abuse is that kids were out of school, they were home. So there was actually a reduction in reporting of child abuse through the normal mechanisms, meaning that teachers might report it, or child protective workers would go to someone's house and report it or whatever. But at the same time, there was an increase in children coming to the hospital, et cetera. So who knows even really what the actual rate of child abuse is, other than it certainly is going up. Other issues such as substance abuse and gambling are also went up during SARS and are expected to be going up now. Of course, many people lost loved ones. There's been a high death rate here. And so bereavement, grieving, post-traumatic stress disorder due to death of loved ones is also an issue. There's also, of course, just stress from social isolation, loss of income, and not to underestimate, 24 hours a day of media talking about the dangers of the virus. One thing that's not on the slide, but I wanted to mention, is that there's also some evidence that psychosis can increase as well. And again, going back about 10 years to studies of people who had coronavirus, the rates of antibodies for different coronaviruses were much, much higher, were quite high. About 90% of people with psychotic symptoms during those pandemics had antibodies to the coronavirus. That was much higher than people in the general population. And so it's thought that possibly psychosis can increase as well. Okay, so in terms of direct effects, I'm going to just go over, just basically pass over this because John covered it all. But just to reiterate the point that in addition to psychiatric symptoms, there are significant neurological symptoms as well. And this last paper at the bottom is suggesting that some of the respiratory symptoms in people with coronavirus may even be due to effects on the brain, especially the brainstem, which is a primitive brain structure that, among other things, controls respiration and arousal and things like this. So there certainly are effects on the brain that need to be studied further, both, again, short and long term. People are starting to organize around this, and there are calls for specific types of research, not only on the physical aspects, but also on the mental health aspects. And this is a very nice paper just from about 2 months ago, calling for an organized research program, which is really needed for this. So I just want to say what some of the priorities are that you'll be hearing more about. One is to just monitor the increase in the prevalence of mental health and neurological problems and disorders. That's easier said than done. So, because it's not always clear how to get the information or whether people are going to respond to requests for information. It's certainly critical to identify the highest risk populations. And I wanted to say what some of them are. One of them is people who are economically and socially disadvantaged. Often these are minority populations. As we've been hearing on the news, African Americans have a much higher rate of infection than white people. And so, again, we need to really have a focus on screening in these high-risk populations. And in this case, also because of mental health issues that are likely to happen. Older people with medical comorbidities are also an increased risk for the virus and for mental health issues. I mentioned the suicide issue before, after the SARS epidemic. People with disabilities, any kind of disabilities, are certainly at elevated risk. Frontline healthcare workers, as I mentioned, children, people with pre-existing mental health conditions, and as John mentioned, people with intellectual disabilities. Not only are they at higher risk of dying from the virus, but they're at higher risk of mental health issues because often they are not as good at coping, or their thinking is more rigid, depending on the nature of the syndrome that they have. And so they're at higher risk for stress, again, as a result of changes in routine like social isolation. There's a lot of talk about using digital assessment apps to get information about people's symptoms or mental health, but we don't really know how accurate those are. Sometimes people's self-report is different than what clinicians would come up with, and so we have to understand that better. And very importantly, we need to identify large groups of people, so have different universities collaborate with each other across different cities, so we can, instead of doing studies of 10 or 20 people, which is kind of what's happening now, we have studies that are involving hundreds or thousands of people. In terms of treatment, as you know, outpatient care was basically stopped during the pandemic. And so much mental health care was remote using Zoom and other telepsychiatric methods. And we don't really know how effective these are, especially when people are, if they're actively infected with a virus. So really we need to study these effectiveness more and try to make them more effective if they're not. There are many digital health apps out there for mental health that people are using, and you hear often how effective these are. But again, we don't know how well they work with people who have mental health issues secondary to coronavirus. One of the issues, of course, is knowing that people are stuck at home and they're under increased stress and likely to be anxious and depressed, what are some ways we can increase their resilience, their coping skills, their ability to take care of themselves physically and mentally during social isolation? I've seen a few articles on this and typical websites, but there's really no research on this. And so this is something that needs to be looked at. Other issues that psychologists think about are things like how to maximize adherence to medical advice during the pandemic while not harming people's mental health by telling them to avoid all people or be scared all the time. people, adherence to medical advice isn't that good even under normal circumstances. And so how to maximize adherence so people aren't getting the virus or getting mental health issues from that. And of course, methods to screen for and prevent problems in healthcare workers is going to be a big issue, especially if we have another surge. I did want to mention here that this isn't strictly a mental health issue, but the recent CDC report, and I have a chart from it on the right here, showed that about a third of people surveyed had engaged in one or more very dangerous behaviors related to things around things like cleaning food with bleach or gargling with industrial strength disinfectants and things like this. So again, educating people and trying to make sure people don't do these things that could be fatal has got to be an area of research. And finally, in terms of the CNS effects, we do need to learn a lot more, and we will be learning a lot more as time goes on about the neurological and the psychiatric effects of COVID-19, especially the delayed effects that may happen from having a brain that was infected. We know from SARS and MERS coronaviruses that the brain was seriously involved in many cases, and in some cases there were delays of several months before mental health issues arose. And so, that's suggesting that there may be some neurological changes secondary to neuroinflammation or other aspects of the virus that take a while to come on. So we have to be on the lookout for that and have a way to study that. We need, of course, to understand better how the brain gets infected. John mentioned one way that's certainly very important through the olfactory system. We're also seeing changes in the retina, which is part of the central nervous system. So it's likely there may be multiple ways that when neuroinflammation happens, blood-brain barriers get disrupted and the virus can get into neural tissue. We need to have easy-to-use tests of these effects. Again, large databases where we study things like psychiatric symptoms, neuropsychological findings, other types of outcomes in people who were infected with the virus. So we can have large-scale studies, not only know what effects are, but who gets what type of effects and what are the different outcomes of people. And I wanted to mention here especially that we need to adopt what is called, and was in fact was developed at the University of Rochester by George Engel, a biopsychosocial approach, which basically in this case means that to really understand the virus and its effects on mental health and physical health, we need to have equal emphasis on understanding the biology of what's happening, but also understanding the environment and demographic, racial, economic, other factors that are affecting people's likelihood of getting it and how they react to it. And then psychological issues around people's pre-existing mental health conditions, their stress reactivity, their interpersonal skills in dealing with people when they're stuck at home with them, et cetera. So really all these things are needed. And of course, there's likely to be other priorities as well, but these are some of the ones that are getting the most attention now. I just want to close by saying that the National Institutes of Health are now soliciting applications from scientists. There's a sense this is a real emergency as well as an opportunity to learn a lot about this. And so there's going to be a lot of funded research happening soon. Okay, so thank you for listening to that. And I would like now to bring back John Foxe and Jennifer. And so we can have a brief discussion and then get to some questions as well.
Great. So thank you so much, Dr. Foxe and Dr. Silverstein. I just want to let everyone know we've had some really wonderful questions. We're going to do our best to cover as many as we can here in the limited time we have together. So thank you so much for your interest and your engagement. I want to start off really with a very specific question that we received from one of our viewers, Allison. This is for Dr. Foxe. She had a question about a specific statistic provided in your presentation. The dysexecutive function that was seen in 33% of patients from that study that was done in France, was that temporary or was that something that had been sustained over the course of weeks or months after those patients had recovered from the infection? Do you know?
Well, yes, I do actually, because so those patients are being followed right now. And so again, if you go back to the timelines here, that study was reporting on data from through April and May. And so those folks are haven't been recovered for that long. So certainly whether these will hang around for months is unknown, because the months simply haven't passed by. But over the course of weeks, those symptoms are still there. And so again, this goes back to the freshness of these data and the numbers of people that you need in a study like this to be able to say anything sensible at all in the first place. And we still have a lot to learn there. It's, typically if somebody has dysexecutive function for a number of weeks out, then the trajectory to recovery can be really quite long. It's, you either recover quickly or then it takes quite a long time. And again, will they persist forever? That's yet to be learned.
Thank you for that answer. So this question is really to both of you. I'll ask you both to chime in on this. We've had several questions posed from our viewers about the impact of COVID-19 on distinct patient populations, and specifically a lot of questions around patients who have autoimmune disorders, seizure disorders, underlying mental health issues. Is there any insight that either of you can provide about these particular patients and where there may be comorbidities or particular vulnerabilities?
Well, certainly there's been quite a bit of discussion, not a lot of hard data, but some that people who have mental health symptoms or diagnoses already are more likely to have worsening of those symptoms, or essentially relative to people who've never had those kind of symptoms, just because of the stress, the lifestyle changes, some of the financial issues, and all kinds of other things that are associated with having the virus. So again, that you have to consider that as a high-risk group for mental health issues. I have to say I'm not so sure about seizures or autoimmune disorders, and hopefully John can.
Well, maybe I can jump in on autoimmune disorders. I know one of the hallmarks of this disease and folks who develop a severe phenotype or severe expression of the disease are those comorbidities, and autoimmune disease is one of those. And going back to the blood-brain barrier, many of those diseases are actually associated with weakening of the blood-brain barrier and general leakiness, actually. And so in autoimmune disease, we really are very worried about blood-brain barrier breakdown. Oftentimes for example, in HIV, we have folks who've also had comorbid addiction issues, and both of those, that's sort of a gasoline on a fire kind of situation. And in that population, for example, the blood-brain barrier, there's quite good solid research showing that the blood-brain barrier is substantially weakened. And so again, that leaves an opening for the SARS-CoV-2 virus to enter the brain. But of course, another question I see coming in a lot here is, well, are these neurological effects necessarily attached to the virus getting into the brain, or could they be to do with other aspects of the disease? Because people get very, very ill, they're anoxic for a long time, they're on ventilators. And that's something I think that at this point, the jury's out on that. It's very likely to be a combination of those two things. There's no question that being as severely ill as many of these folks are when they're on a ventilator, whether they had SARS-CoV-2 or not, they would end up, they might often have a long tail to the disease where they would have some neurological implications. So the best guess is it's a combination of both of those things.
And to follow up on that, Dr. Foxe, there are, brain infarcts, blood clots, pulmonary embolism, et cetera, have been identified in patients with COVID-19. And some reports have emerged that really link the virus to inflammation and different inflammatory disorders. Sort of following up on that discussion of a compromised blood-brain barrier, can you comment on some of the potential connections that exist between those phenomena?
Well, yeah, so I'm not a hematologist, but going back to some of my basic training, the blood vessels, and everybody on the call will know this from worrying about things like cholesterol and atherosclerosis and so on. The blood vessels, the layer inside the blood vessels, the endothelial layer of cells, provides this very nice, smooth, slippery surface so that blood can flow back and forth through all the blood vessels, down to the very, very small ones in the capillaries. One of the suspicions of people in the field right now is that the virus is infecting those endothelial cells. Why? Because the endothelial cells express this ARC2 receptor. So as you've all seen the cartoons of the COVID virus with the spikes, the spike protein on the virus attaches to a very specific receptor that's lovingly known as ARC2. And those endothelial cells have that ARC2 receptor. So the idea here, or the suspicion, is that the virus is infecting the endothelial cells, causing that smoothness to get roughed up as they become inflamed, and then you get some sloughing off of materials. So it started acting a little bit like atherosclerosis does, and so that's why we're seeing this blood clotting phenotype or expression in more than a third of the patients. And of course, that can happen systemically throughout the body, including in the brain, where these clots would cause little mini strokes.
Great, thank you. Dr. Silverstein, the next question's for you. As a society, we've really all been affected by the need to socially distance and adjust daily routines. How do you think that the pandemic has disproportionately affected individuals with underlying conditions, particularly those with underlying mental health conditions, or maybe those who lack or might be separated from a support network? And then additionally, does a living situation, your environment, does that really play a role in mediating sort of the psychological response to the disease?
Well, those are great questions, and I think I'm very confident that there are going to be grants given out by the National Institute of Health in response to that request I showed before to address some of those issues. So, in terms of this specific virus, I don't think we really know, but clearly the answer is yes to many of those questions in general. So people who have underlying mental health conditions, generally are not functioning as well, coping as well, and even thinking as well. And by thinking, I mean being as flexible in their thinking, having executive skills or decision-making or planning skills that are as good as other people. So people with depression, for example, people with psychotic disorders, it's known that it affects their ability to function every day to day, as well as just think through things and make good decisions. So now if you have those problems and you have, let's say, depression, and now you've lost your job and you're stuck at home and you can't go out, yes, you are at a much higher risk. So all these things seem to interact is what people think. And I guess one thing I was trying to get at before is, many of these conditions like depression, mainly maybe, and anxiety, there are some very effective treatments for. But treating people at home who are stuck at home with a bunch of other people who are stuck at home, where everybody may be more anxious, that's kind of a new situation that mental health field really hasn't dealt with before. And so that's why there really has to be some new research and probably new approaches developed to help people here.
Excellent, thank you. Dr. Foxe, I want to come back to some of the concept of a long-term implication for COVID-19. I know you talked a little bit about vertical transmission, but researchers are continuing to realize the power of epigenetics. And we had a great question from one of our viewers that asked about whether or not there was any evidence or sort of inclination based on our knowledge of other coronaviruses that epigenetics was involved. So those heritable changes that do not involve the sequence of DNA or alterations in that sequence, but sort of all the flags and tags on top of that create some of those heritable conditions that we see. Do we have any idea whether or not that may play a role in this disease in particular?
So I think it's too early for us to know about any sort of epigenetic impact on the next generation, right? So, but we have lots of hints from previous issues like this. So for example, wartime causes epigenetic effects, large societal stressors. Particularly severe flu season can cause epigenetic repercussions that play out over the course of decades and generations. So I think it would be reasonable to say you can take it to the bank that there will be epigenetic impacts of this COVID-19 virus, but it's way too soon for us to be able to say too much about it. Now, what I will tell you is in many of the large-scale longitudinal studies, the University of Rochester, for example, is involved in one called the Adolescent Brain Cognitive Development Study. That's a study that's an NIH-funded study that's following 12,000 9-year-olds fully for a decade. And in those, and we're one of the sites for that. I'm actually the principal investigator on that. We're taking bloods on the children at regular intervals and taking biological samples. And of course, some of our children are going to become infected with COVID-19, as are their parents, and some already have. And so the entire network is working on harvesting, if you like, the biological samples. We'll need to be able to make some judgments about that. So stay tuned, I'm afraid, yeah.
Great, thank you. Now this really will be to both of you to discuss some of the questions that we've received about how this novel coronavirus compares to other viruses like flu or Zika. Is there any commentary you can provide about maybe some of the similarities or differences between these, really with regard to physiology, risk, psychological impact? Can we learn from these other diseases and other viruses, and how do those seem to be playing out from a clinical perspective?
Well, I guess I'll just say that, as I mentioned briefly at the beginning of my presentation, many of the projections for this second wave, essentially, of mental health problems comes from data from the SARS and MERS pandemics or infections, a number of years ago. And, but it certainly seems that there are going to be more cases here of coronavirus than COVID-19 than of those coronaviruses. So again, all the projections are, it's not really controversial that there are going to be significant increases in depression, anxiety, suicide, child abuse, et cetera, and possibly even psychosis in the short term. And then just to get back to something we were talking about before with, people who are essentially embryos or fetuses are in development now whose mothers are infected, it wouldn't be surprising if 20 years from now we see an increased rate of serious mental illnesses like bipolar disorder and schizophrenia, knowing that those mothers who have influenza during especially the second and some cases third trimester tend to have children at much higher risk for these things. So we're already seeing some of this evidence in the short term, and I expect it's going to surpass what we saw with the prior coronaviruses.
Yeah, go ahead. Sorry, I'm not a virologist. I'm an amateur virologist, but I think Steve puts it very well. We know from the previous outbreaks, they weren't pandemics, but we know from the previous coronavirus outbreaks that there are long-term sequelae. We also know from the flu, and I just want to make a very clear point here. I don't think it's a secret to most of you. This is not the flu. This is a much more serious thing than the flu. And people get a lot sicker with this disease, and a lot more people end up with a very serious disease phenotype than with the flu. And so I think, again, a little bit of common sense here. If people are very, very ill while they're pregnant, for example, the impacts on the developing fetus are likely to be more severe. And so we, as Steve says, this will play out now over the next 20 to 30 years. And we very much expect to see upticks in those kinds of phenotypes and those kinds of clinical presentations in the offspring.
Well, I just want to, again, I want to thank both of you. Unfortunately, we can't get through all the questions that we're getting. We've got some really excellent ones. So I do hope that we can continue the conversation at some point. But I'd like to thank both Professors Foxe and Silverstein for a really wonderful session. Do either of you have any other last comments that you'd like to share before we wrap up?
Well, I guess I just want to say, I don't think I've ever spoken to 700 people before. Unfortunately, I couldn't see any of them. But thank you all for listening, and I guess people can submit other questions if they have them later, and I think John and I will try to answer as many as we can.
Yeah, I'd like to thank all of you folks out there who have a connection to the University of Rochester and have been such staunch supporters of what we do. We're here working on these critical issues every day. we intend to work on providing the very best possible outcomes for patients and the children that are going through this very difficult time. And so thank you for your support, and stay safe out there. Wear a mask, socially distance, stay safe. That's very important.
Right.
Well, thank you both again. Thank you all for joining us today. We hope that you enjoyed this program, and we would love to hear your feedback. Please take a moment to share your thoughts about the session through a brief anonymous survey. The link for that survey will appear on your screen at the end of the webinar, so just select continue to get to that questionnaire. We will have additional Experience Rochester lectures throughout the summer, so please keep an eye on your email for those details. We hope to see you all again. I hope everyone has a great afternoon and stay well.